Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could do and answer during the broadcast portion of our show, so let's get started. A car accident 6 years ago, fractured ribs, still having problems. What can I do to help it? Fractured ribs with pain that's chronic. Now that's uncommon for me. I have not seen that. You think it might be something else, Jonathan, a back?
Fractured ribs are difficult to heal. They take a lot of time to heal. It could be related to the back. How far out did you say it was? A year?
6 years.
6 years. I think it's worth looking into and seeing maybe there's something else that's going on.
Yeah. Any of the other?
I would just say the specialists in chronic thoracic pain after trauma are the thoracic surgeons. So if that was me, I'd go see Tommy Reynolds or somebody like that.
Tommy Reynolds. Yeah. So maybe we're into the realm of chronic pain syndrome, which is just this whole different bird. I just lost. A 75-year-old man. I know tore the muscle off the top of his leg. It is now retracted. They told him it would be a major surgery and he'd better live with it instead of going to surgery.
Yeah, so it sounds like a quadriceps tendon rupture like we were talking about before, but it was unrecognized. Now it's retracted. There's a gap there. Some of those patients do okay. If it's a partial rupture and he's still got some strength to keep his knee out straight and he can bear weight, it may be better off treating that non-surgically. If he really has like kind of a flail knee and he can't bear weight on it, there are reconstructive methods to fix that. Yeah, it's a big deal.
But the sooner the better.
Oh, absolutely. If you're going to do something, you want to do it now. Yeah.
Right, before the muscle just kind of go...
Right. It's atrophying and getting tighter every day.
I have bad neuropathy in my feet, which I take medicine for. It came after I had cancer and chemo. Do you know of anything that can help neuropathy? Well, let me give you... I'm the guy. I've had neuropathy from chemotherapy just like you. And I have to say one thing is neuropathy or dead. I think I'd rather have the neuropathy. And I had one patient, a friend of mine, say, well, it's been 1.5 years now. Finally, the feeling is back in my feet. I also know that certain antibiotics, Cipro and other things, can make the neuropathies worse, so we've got to be careful about antibiotics. I would also say that if you look at the neuropathies that can occur, many times they're vitamin B dependent. A person can get B12 deficiency and have peripheral neuropathy. A person can have B1 deficiency and have Korsakoff's dementia and all sorts of other neurologic things. So I would, what I am doing now is a vitamin B1, a vitamin B12, and a B complex. Whether it works or not, I'm not sure. I have, my general internist told me to rub Vicks Vapor Rub on it. Just watch carefully your feet, make sure they don't get sores, be meticulous with cleanliness. And that's my take home. Live with it. Know that the chemos that we have now that are causing neuropathies are also keeping people alive that would be long gone. So thank you, dear Lord, for the chemotherapy, and okay, I'll live with some of the complications. How was that?
That was awesome, and your hair's different too.
Yeah, I bet it does something to your hair. This person has bursitis in her hip for 6 months and is wondering if that is a long time to have it and what could be done for pain management.
Yeah, so chronic greater trochanteric bursitis, extremely common in our patients over the age of 60. Difficult condition to treat. There really is no magic surgical procedure, pill, or injection that makes it all go away. So the three mainstays of treatment are physical therapy for specific stretching exercises that we then usually have the patient do on their own at home, non-steroidal anti-inflammatories when they're effective, and occasionally a corticosteroid injection into the bursa to decrease the inflammation.
Ooh, when that works, it's bad. They
awesome.
love you.
Yeah.
They do.
Yeah.
That's a good thing. I had a call about the question of how long does a total knee last? I mean, sometimes you need to replace parts, right?
Right. So this third generation knee that we're putting in now, I tell my patients, is probably a 30-year knee. Just historically, the problem has been the plastic wears out. And the new plastics, irradiated cross-linked, it's impregnated with vitamin E, and in the lab it doesn't really wear at all, but we're sure in the patient it will. It's true that if that thing wears out, it's fairly easy to go pop it out and snap in a new one.
Okay. So I was a runner before this whole cancer thing, and I was addicted and I loved it, and if I had a bad knee, I would want my knee replaced and then run again. What do you say about running again?
I tell my patients they can run again. I don't put any restrictions on my patients long-term
Yes!
knee replacement. Yeah.
I can't tell you how happy that made me feel. I have scoliosis at 30% on the left side. I have a lot of pain and osteoarthritis. Now my right area of my back and down my leg is hurting. I've had a lot of pain and I've been told no surgery. Is there anything else can be done? I don't know how old this person is. Jonathan, what do you...
There's several options here. So if you have a scoliosis and now you're having pain that goes down your leg, the back pain associated with it, very difficult to treat. The leg pain associated with it, there are some good options for it. We could start with injections. You get an MRI, and then you really hone in on that area that looks the tightest. You correlate their physical exam to their MRI imaging, and if you can correlate something, get an injection right there, do a nice transforaminal epidural. If that gives them relief, that's great. We can do a couple more of them. If symptoms continue to come back with the scoliosis, and you can do just a limited, maybe a one-level decompression or a real minimally invasive treatment, just short of not doing the whole entire fixing everything. So there are some smaller things that you can do to give some people some real relief of the leg symptoms.
So when I grew up in medicine, they had these Harrington rods. I mean, a rod that would go all the way down the spine, and then they would pull one side in and pull the other in and pull, and it looked just horrible. Mm-hmm. How successful was it? Are they still doing them?
That was the pioneering beginning to the correction of what we do with internal fixation. That's the thing that got people out of body casts. It really, it may have looked barbaric, but it did amazing things for people. I mean, I've seen people in clinic that had those put in back when you were talking about,
right,
and they did so well for so long. And these are people that, if they didn't have that treatment, their curves would have progressed to the point where they get
lung disease,
yes,
heart disease.
And they died. They died at a younger age.
Yes.
So it may look barbaric, but again, like you were talking about with chemo and neuropathy, there's a yin and a yang here, and it's life or deformity. So it's worked well. We have new fixation techniques that work even better now, but at the time, that's pioneering, and it's the forerunner of what I do now, and I'm very, very grateful for the work that Dr. Harrington did to develop those. Also, the work he did at Twin Cities Spine, where I trained, where he helped develop
that's
it.
where you trained.
Yep.
Here's a last question, and I don't know if I can get it all. Do you treat a meniscal tear differently depending on, and I can't get the rest of the question, but let's just talk meniscal tear, because a lot of people get them.
Right.
There's some debate about whether, there's a time to do them or not to do them.
So number one, every meniscal tear doesn't need surgery. I tell my patients, there's a lot of people walking around with meniscal tears on MRI scans, and I tend not to I tend not to treat based on MRI scans. I treat the patient. So if the patient's got
the patient.
What a crazy idea,
Gee,
right?
how could you come up with
the
this
patient's
idea?
got a problem and they've got pathology that matches their problem, then arthroscopic surgery for meniscal tears is incredibly effective. Sometimes we're able to repair the meniscus. If the tear is through the outer 15% of the meniscus where there's actually blood supply, you can put stitches in it and expect it to heal, especially if it's a younger person, especially if you're doing an ACL reconstruction at the same time. Older patients, the more common tears are through the thinner inner portion of the meniscus, which has no blood supply. You can put stitches in it all day, it's never going to heal. A simple excision of the torn portion, leaving all the good healthy meniscus in place, gives tremendous relief. And I've been through a couple of those. I don't know. Yeah, you've been really lucky. I've never had to do that to you, right?
No, you've never touched me. No, but the whole idea of an older person with a meniscal tear, sometimes it really is an appropriate thing to do.
Yeah, so if it's just part of their osteoarthritis, it's been shown over and over again that going in to scope those patients does not give them long-standing relief. You're just wasting health resources and not making a difference in their life.
Right.
If, on the other hand, they have very little osteoarthritis and they were doing fine until they tore their meniscus, so you treat them just like a 30-year-old, you know. Just because you're old doesn't mean that you're decrepit, right?
Yes, no, that's right. I like to hear that. So, well, I thank you guys very much for volunteering to do this. And I'm going to give you 3 times as much money as I'm going to get for doing this afterward. Thank you for joining us on our Facebook page. We appreciate all of your questions and the opportunity to answer them. And so until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.